Good morning, everybody. Like to welcome you to Grand Rounds. It's good to see you all here. Quick announcement. Given all the coronavirus fever, we are going to have Justin Jin. We invited Justin Jin, who's infectious disease doctor, who's part of the committee overseeing the Providence response. He's going to come at the end of the lecture today and give just sort of an update and let you know about what Providence is doing in terms of what testing is available, et cetera. So if you have time after, we're thinking around 8:50, he's going to join us, and there'll be some Q&A at that time. But this morning, I'm super pleased to welcome Dr. Benner to speak to us about hepatitis C. As some of you may have seen, the screening guidelines just changed from the U.S. Preventive Services Task Force to include screening all adults age 18 to 79 at least once, not just the wild and free-living baby boomers. It turns out the highest demographic is the young people with IV drug abuse. And screening recommendation is changing because we now also can treat and cure hepatitis C, and that's the aim of the lecture today, including disseminating that treatment out to us primary care providers. Dr. Benner is a specialist and an expert in this area in hepatology and hepatitis C. He graduated from UCLA and did his internal medicine and internship and residency at the University of Colorado. He completed 2 fellowships in gastroenterology, the same year I was born, incidentally, one at the University of Washington in St. Louis. It's a congratulations for both of us, Dr. Benner. And the other at OHSU. He serves on a number of panels, including the International Liver Transplant Society. He was director of transplant at OHSU for a decade. He's chair of the NIDDK for the National Institutes of Health. He's a reviewer of many gastroenterology journals, and he has served on the Oregon Health Plan Hep C Advisory Group since 2014, and he is a national speaker on hepatitis C. I saw him down at ACP in Salem this past year and thought he did a phenomenal talk. Please welcome Dr. Benner.
Thank you very much, Jesse, for that kind introduction. Think of this as an introductory talk for the talk at the end of the hour on the new viral challenge. I plan to briefly review the scope of hepatitis C from when I was an early trainee in non-A, non-B hepatitis, when we were trying to define the epidemiology of the virus, the course in individuals, how we might treat it. And since those days in the late 80s, we've come a long way where we're going to now be talking about hopefully the fading aspects of this outbreak of hepatitis C with targeting elimination. 30 years ago, the focus on hepatitis C was trying to identify what the virus was. Recall that the identification of the virus came out of industry with the help of the NIH in providing hyperinfected serum. And that discovery wasn't published in the medical literature, but it was in the New York Times. And when I was a junior faculty member, we were just starting to treat what was new hepatitis C that we could diagnose with the antibody testing that came from that industry research using interferon and ribavirin. The patients were in usually university hepatitis clinics, and that's where most of the treatment went on. And when we grew to realize how toxic the interferon medication was and how ineffective it was initially, we shifted mainly towards treating patients with more progressive liver scarring. Since about 2014, we know that the novel direct-acting antivirals are highly effective, and in the combinations that are now available clinically, we have very high cure rates that are very well tolerated. And it's with this background that this has shifted into public health and trying to eliminate the virus completely because of the ease and the efficacy of the therapy. Just by way of global perspective, It's estimated about 1% of the population of the world is infected, most of it in Europe and South Asia, North Africa. The 7 countries listed here account for about half of the infection in the world. The highest prevalences are in Egypt, Georgia, Pakistan, Russia, and Mongolia. And it's estimated about a fifth of the hepatocellular carcinoma worldwide is from Hep C. But if you consider countries where hepatitis B is non-endemic, it's probably closer to 70 or 80% of the hepatitis C is attributable to, or the hepatocellular carcinoma is attributable to hepatitis C. There are about 500,000 deaths around the world from the virus. It's also estimated by some recent assessments that infection rates are continuing to grow in most of Asia, North Africa, and the Middle East. Most of that comes from healthcare-related transmission, although that is dropping significantly in recent years. For example, the infection rate in Egypt is nearly 24%, and probably most of that occurred with public health treatment to try and clear schistosomiasis back in the 50s and 60s from unclean needles. Having said that, the Egyptians are some of the most aggressive in the world and have been treating hundreds of thousands with general population screening, and are targeting elimination in the next 5 to 10 years. What's allowed this successful approach to treatment is the increasing efficacy of the regimens we've been using. When we started treating patients back in the late 80s, our cure rates were about 10%. When I left academics and came to the Oregon Clinic, our cure rates were somewhere around 55%. And when the direct-acting antivirals became available in 2013, it jumped to 90%. And as we've gotten better regimens, we're now at about a 97% cure rates for all patients treated. And these cure rates hold up regardless of the degree of liver injury. The general population's become aware of this. This is an advertisement for Medicare coverage in recent years and the 4 drugs that are available. And this is advertisement to our patients telling them we have these drugs available and the cure rates are over 95%. And you'll notice that 2 of these drugs will treat all genotypes. This is the Epclusa drug and Mavret. So it no longer, with those regimens, necessitates genotype testing. Well, what do we accomplish with clearing hepatitis C? We've become aware that not only do we markedly reduce fibrosis and necrosis when the virus clears, but some cohort studies from the interferon era with serial biopsies show that nearly half of individuals with cirrhosis and hep C rebiopsied years later may actually resolve cirrhosis. There's large reductions in risk of liver cancer, as high as 90% reduction in liver-related deaths and transplantation. But we've also learned in recent years that there are also impressive improvements in extrahepatic manifestations and all-cause mortality. And we're starting to understand this a little bit more. Not only do non-Hodgkin lymphoma and lymphoproliferative disorders associated with hep C often improve or resolve with hep C clearance, there's also good evidence that health-related quality of life, fatigue, and absenteeism from work are markedly reduced by viral clearance independent of degree of liver injury. So fatigue can be markedly improved in individuals with minimal liver scarring with hep C clearance. There's also growing evidence that diabetes is positively infected among hepatitis C infected persons with viral clearance. There's about a 3-fold increase in the incidence of diabetics and hep C infected persons over age 40. And there's data that insulin resistance improves and diabetic control improves when hep C is cleared. And there's recently some data from Japan showing that complications of diabetics and hepatitis C individuals that clear results in less development of end-stage renal disease, ischemic stroke, and acute coronary syndrome. So based on this success of using medication, several of these high incidence areas really focused their public health approach on trying to clear the virus from the population. This is some data from the country of Georgia from 2015 to 2017, whereby the World Health Organization, CDC, industry collaborated with the national health system to set up diagnosis and treatment with strong political support. Early last year, there were about more than 10 countries around the world where local manufacture of these drugs got the total cost of treatment to below $200 per patient. And it's this sort of economics that can drive this sort of success. In this period from April of 2015 to late 2017, 40,000 patients were treated. They reduced their incidence by 21%, and they're targeting their elimination targets, and we'll probably get there long before we do here in Oregon. As we know, the VA targeted hepatitis C treatment in 2014 and 2015, and one of the challenges in the VA as well as around the world was not only diagnosing the patients that were infected, but linking them to care and getting treatment started. And you can see their success rates back in 2015 were modest. They were only treating about 51% of their identified patients. This had improved by 2018, such that about 68% of VA infections that had been identified were successfully cleared. I think my clicker stopped working here. Okay. Is there another option for advancing slides? That one. No?
Maybe it's where is the mouse? That one?
Yeah.
Okay, try it again. Now do it again. There you go.
Okay, we're good. So the World Health Organization, thank you very much. World Health Organization focused on viral hepatitis, and in 2017 presented goals for elimination worldwide for both hepatitis B and hepatitis C, targeting a 90% reduction in new infections and a 65% reduction in deaths by 2030. And this was followed by the National Institutes of Health and Medicine to present a strategic plan for elimination in the US in 2018. So where do we stand more locally? This is projection of data from the NHANES database, which surveyed hepatitis C prevalence in the US. And the data was corrected for important populations that aren't included in the NHANES survey, including the homeless and institutionalized populations. And they also used some data-specific HCV mortality from various states. Bottom line here is Oregon is in a high prevalence group of states around the country with hepatitis C. And in fact, mortality data from Oregon exceeds that of the national average, particularly since 2010, almost twice the national average. And we had the distinction for several of these years of being the highest death rates in the country for hepatitis C. And if you compare hepatitis C mortality in Oregon to that of HIV, you can see it's really not only above the national average, but far above HIV deaths. This is data generated from a survey conducted by the Chronic Disease Assessment Foundation, which is a group of epidemiologists and public health individuals that go into populations and try and estimate the incidence of the disease, the burden in the community, and then use this information to try and project effective treatment strategies. And these are the estimated incidence rates of new cases in Oregon since 1950. We know that the peak transmission was in the 80s, but the other concerning development has been the rise in new hepatitis C infections since 2010. This is more specific data of newly diagnosed chronic hep C cases reported to the state health department in 2015 and 2018. And you can see there's this peak of incidence in the teens to 40s was recognized 10 years ago and was increasing by 2018, such that if you consider the recommendation of cohort screening for those born 1945 to 1965, in 2018, that would be about age 53, and you would miss all these people based on birth cohort screening in Oregon with that strategy. To put some of this in context, this is data from 2016 of new acute hepatitis C cases nationwide. 80% were found to be IV injection drug related, which represented a threefold increase since 2010, paralleling injection drug use, mainly in the youth population, often developing after transition from prescription opioids to heroin. And concomitant with this was an alarming rate in hepatitis C infections among young pregnant women. I was often curious as to how we managed to get the distinction of having some of the highest rates in the country, and it's hard to get specific information on drug use around the country. At least I'm not an expert in this area, so I resorted to probably one of the poorest sources, which is the internet. This is from Wallet Hub, looking at a lot of data, and we had the distinction on this website to be 12th overall as a problem area for drug use in the country, and they found that we had the highest adult drug user rates, the third highest teenage drug user rates, and the fifth fewest treatment facilities for drug use per 100,000 in the country. Now, how true this is, I don't know, but I thought it was provocative. This is data on hep C incidence between 2011 and 2015 in Oregon by county. And we know that infection in rural areas is a problem. And we can see several rural areas with particularly higher infection rates. This is also data in 2019 looking at acute drug users and hep C infection. And in this cohort, about half the individuals were infected with hep C. And half of them knew at the time they were contacted that they were hep C positive, and only a fifth of those that knew had been treated. So not only is it prevalent in the drug-using population, but these patients haven't been treated. So last year, the state got a grant to get support from this Chronic Disease Assessment Foundation, and convened a group of individuals, not only in the Oregon Health Authority, but treaters around the state, Department of Corrections, Medicaid program, the Portland Area Indian Health Board, and tried to define as best they could how many patients were infected in the country, what the chronic load was, and what the natural history of the infection in the population would look like in the future. And based on the best information that this group had come up with, in early 2018, it was estimated there was about 57,000 active infections in Oregon, and that about 63% of these patients were diagnosed. So better than 50%, but still a long ways to go. About 11% were in active IV drug users, and about 20% of these folks were in Medicaid. When we plug the information into the models of Markov models to try and project course of the disease into the future based on best information, these curves are generated, and the various dots here are various stages of liver disease and the number of patients in Oregon with the various stages. The orange line here is cirrhotics, and you can see by about 2015, we had about 9,000 cirrhotics with hep C in Oregon, and we believe this is going to slowly taper down, but we're going to have a high burden of cirrhotic patients into the next decade. This blue line here is the total number of infected cases in Oregon. And it's believed that this peaked somewhere around 80,000 in around 2005, 2010, and then started dropping. And in about 2014 or 15, the rate of drop accelerated with more generalized use of the DAAs. And when I eyeball these numbers, it looks like there's been a reduction of about 12 or 15% of the number of cases in the last 5 years in Oregon. Probably, so it's decreasing at a rate of about 2.5% per year of the total infected cases. Probably about a quarter of those were deaths of patients with Hep C, and probably 3/4 were treatment. And the average number of patients treated in the state was probably averaging over the last 8 years about 1,200 to 1,300 patients. Looking at pharmacy data, which this group had access to, in 2018 there were over 3,000 prescriptions written in Oregon, including data in the VA system. Or let me just make one more comment. So if we're projecting to try and get down to much lower numbers of infection, we have to steepen this curve of hepatitis C clearance. And that will require higher numbers of treatment. Now, those of us in the business of treating Hep C have pretty much treated all the patients we have. The more advanced liver disease patients in GI groups were treated, and it looks like the maximum number of patients treated per year are actually dropping around the country because we're running out of patients that we've identified to be treated. It's estimated that about 1,400 Oregonians acquire new Hep C every year. There are about 4,000 new Hep C chronic cases identified each year, and that we're treating about 3,600 as of 2018 and curing about 3,400 of them. So at this rate, if we have 5,700 patients infected and we're curing 3,400 a year, we're going to have to double our rates of treatment to clear this infection. In 2016, a group, the Hepatitis C, or the Viral Roundtable, graded each state around the country in the Medicaid system about what kind of a job they were doing diagnosing and treating Hep C. Oregon had the distinction of not only being one of the highest rates of Hep C in the country, but having one of the poorest grades of dealing with the Hep C infection. And this was largely based on published CCO criteria for treatment in terms of who was allowed to treat, fibrosis criteria requirements, and have abstinence from drug use. A group of advocates in the state got together and started actively engaging government and public health authorities to try and move the ball on this. And actually, the Oregon Law Project got involved in 2016 and started negotiating with the health department legal remedies. And it was concluded that the Oregon Health Authority would redouble efforts to get funding, and they targeted the end of 2018 to try and reduce most of the obstacles to treatment within the Medicaid system and to ramp up funding. And in fact, in March of last year, the Oregon Health Plan essentially dropped all criteria based on restricting treatment to specialists, requiring abstinent periods, and requiring advanced fibrosis for treatment. In April of last year, the Oregon Health Plan sponsored a learning collaborative with a lot of the CCOs about best practices to get treatment and diagnosis out to the CCOs around the state. And as we've discussed, this modeling project was initiated to define burden of disease and target most effective approaches. This is just some cartoons about where we stood back in 2014. In Oregon, the orange states were in good company, requiring either treatment by specialists or requiring specialist GI hepatology consultation to treat. In 2018, it was about the same, but 2019, there were no restrictions on treatment. In terms of severity of disease, in 2014, you had to have cirrhosis to get treated. In 2018, you had to have stage 2 fibrosis, and then all restrictions based on fibrosis were eliminated in 2019, and also absence of 6 months, which was required for drug use and alcohol, was dropped. And this was based on data showing that active alcoholics and recent IV drug users can be treated successfully with high viral response rates. There's also been evolution in screening strategies. We're aware that the cohort screening was suggested about 10 years ago, and it's estimated that this is captured probably 70-75% of persons in that group. The Providence health plan approach to having a pop-up for hepatitis C screening in the cohort has been very successful. In 2017, about 20% of the cohort was being screened. As of late last year, it was up to 76%. Having said that, with so many persons infected in young age groups, the latest recommendation from the task force, as Jesse mentioned, has been to screen all adults from 18 to 79, and this now corresponds to the same recommendations from the Liver Society and the ID Society. And annual screening is recommended for those at particularly high risk, current IV drug users and men who have sex with men. The goal established back 5 years ago to try and improve linkage to care in 2020 was up to 66% from 50%. We're getting closer to that in Oregon, but the problem is still that a minority of patients are receiving treatment. On the back of the envelope estimate I came up with was there's probably 12 to 15% of Hep C infected persons in Oregon have been treated at this point. One of the challenges has been going through the diagnostic and testing cascade to inform patients that they're infected. Our traditional approach is to get an antibody test at the phlebotomist, have the patient come back, get a confirmatory test, and get a diagnosis. There's now in development dot RNA testing that can be performed at site of visit, which has a potential of making a definitive diagnosis at initial contact. And the ideal approach would be to diagnose and treat at one location and to try and capture patients that are difficult to engage in the healthcare system. This is data of IV drug users in Oregon. This is from up to 2013. Again, a high percentage were IV drug abusers of acutely infected cases. And by this age 50 to 60, 50 to 100% of individuals with chronic IV drug use were infected. What about treatment of patients with active or recent IV drug use? Patients in medical opiate treatment programs, clearance rates are in the 90% range. Those with recent IV drug use up until the initiation of treatment in these studies was about 87%. Some of these studies were prospective randomized trials. Some of them were observational real-world trials. The real-world trials outcomes weren't quite as good, but the observation was that the poor outcomes in the observational trials were related to loss to follow-up rather than ineffective treatment. Part of that, I think, is explained by this data. This was a study that monitored the actual pill taking of patients with a history of IV drug abuse on treatment and looked at adherence. There was a 97% adherence of number of pills taken overall, or I'm sorry, 94% overall. About a third of the patients took less than 90% of their tablets in the prescribed treatment period of 2 months, but they finished it up after that with their leftover pills. Regardless of that, there was still a 94% viral clearance rate. So the point here is you can get away without taking all your pills and still clear the virus. We don't tell our patients that, but that's in fact the case. Another bit of information out of Europe is among IV drug users that clear the virus, or that have the virus, transmission rates can be reduced by about 74% when there's a combination of opiate substitution and safe injection equipment provided. But a minority of countries provide these. Around the world, Australia and New Zealand has the highest rate of needle exchange, about 200 needle exchanges per user per year, which is the recommended level that the World Health Organization advises. The US average is about 30 needle exchanges per year. Drug treatment coverage in Western Europe, Holland is way out ahead in terms of treatment of active users, but it looks like best practices based on data generated out of Europe is that minimizing transmission is best accomplished by both providing opiate substitution and clean needles. What about reinfection? This is a meta-analysis from presented at the European meetings last spring, looking at a total of 5,000 IV drug users and looking at reinfection rates. Bottom line is it's about 5 infections per 100 person years of follow-up. And it tends to get less as time goes out. So yes, there is reinfection, but it's at acceptable rates. And it's argued that if you're not getting in reinfections, you're not treating the population that is putting others at risk for transmission. So how can we approach to getting the treatment out to the people? Well, obviously, the key is going to be primary care providers, addiction medicine specialists, as well as opening this up to physician extenders, PAs, NPs, clinical pharmacists. And the role of the specialist will likely be facilitating education, training, and then treating the tough cases, retreatment, and those with advanced liver disease or co-infection. And there's a lot of novel approaches being developed, one of which is at Central City Concern. And Dr. Andy Seaman has got a trial going where they're actually treating in the residences, diagnosing in the residences for people living in the Central City Concern establishments and treating them at their home. In terms of novel approaches close to home, the Providence Pharmacotherapy Clinic has been treating Hep C. The clinical pharmacists at the clinic have been treating non-cirrhotic patients since the fall of 2017. They've treated about 300 patients. And here's their referral system number or letter right there in case you'd like to refer your patients to them. If you diagnose a case, they're up and running and have been doing an excellent job. By way of conclusion, this is the new simplified treatment algorithm that was just released in the last month or two about how to treat non-cirrhotic patients at the primary care level. And this is the handout that I had on the way in if you'd like to take a look at it, and it's available online. The bottom line is when patients are diagnosed with RNA testing, they'll qualify for this if they don't have cirrhosis and they've not been previously treated. So we also want to have patients to have normal renal function, absence of HIV or Hep B, be non-pregnant, and have no hepatocellular carcinoma or post-transplant. And the basic workup of these patients is very simple. Calculate a FIB-4 score, which we'll look at here in a minute, and is an online calculator that you can access through the ASLD IDSA website. If they have a FIB-4 score less than 3.25, we can consider them non-cirrhotic, or you can look at any other clinical evidence, including FibroScan or other transient elastography techniques, serologic tests, fibrometer, clinical evidence such as nodularity on imaging, splenomegaly, or a prior liver biopsy. Any of these will qualify. This is the FIB-4 score. This is just AST, ALT, patient age, and platelet count, which is a pretty good job of guesstimating patients with advanced liver injury. The next step is to do medication reconciliation, get their medication list and herbs. St. John's wort can interfere with some of these drugs. Potential drug interactions are important. We know that many of the drugs we use have potential drug-drug interactions, but they're excellent charts in the ASLD website, as well as the drug interaction checker provided by the University of Liverpool. I'll show you that website in a second. Education is key. How to take the medicines, adherence, prevention of reinfection, particularly among active users. This is the University of Liverpool drug interaction website. This we have on our cell phones. It's an excellent website. You put in the meds, it tells you what interactions are and what you might need to do about it. Another way to deal with this is just call your clinical pharmacist if you have one nearby, or send them to the pharmacotherapy clinic and they take care of all this. Treatment, all you need to do is get a blood count, chemistry panel, GFR, quantitate the RNA. We don't need a genotype because the drugs we're using are pan-genotypic. Screen for HIV and Hep B. These patients probably should be treated with folks experienced in their management. Before initiating antiviral therapy, obviously screen for pregnancy. Now this whole pregnancy and Hep C treatment, there's some advocacy going on to start treating pregnant women, but it's got a lot of obvious challenges. But there is interest in pursuing that. The recommended regimens are these two regimens, which are pan-genotypic, all genotypes. The first one here, Mavorite, treat for 8 weeks. Second's a 12-week regimen. Patients can become hypoglycemic if they're diabetic, so they have to watch carefully their blood sugars. There can be some INR changes, subtherapeutic anticoagulation, particularly with warfarin, but also the non-warfarin oral anticoagulants. It's really not, we at this point don't monitor our non-cirrhotic decompensated patients unless there's a specific concern during treatment. And we also don't even check an RNA at the end of treatment. We just track a 12-week RNA to establish cure. It's also recommended to check a transaminase 3 months after, along with that check for cure, to see if they have persistent elevations, and if so, think about other diseases they may have. Things that are not uncommon, as we know in the population, are fatty liver. Occasionally we have an autoimmune hepatitis combined. Follow-up after cure, not required unless there's ongoing risk for reinfection from high-risk groups. Avoid alcohol. If they need retreatment, that's probably the time to have them sent to someone who has a little more experience with treatment, but we do have good retreatment regimens. Compensated cirrhotics, define that by their Pew Child score. If it's 6 or 5 or less, they can be treated. This basically means that if they have any of those indicators of intermittent or intermediate range, bilirubin elevation, trace ascites, mild encephalopathy, one of those things is okay, but more than one in a mild degree, they're decompensated. Want to exclude HCC with an ultrasound in cirrhotics. Same treatment with Mavorite if one's using the sofosbuvir-velpatasvir combination. This requires special resistance testing for genotype 3 patients. Monitoring blood tests may be a reasonable thing in the cirrhotic patient. If you see any bumps, send them to the specialist. Cirrhotics will need to be monitored for cirrhosis once the virus clears. We know that, again, cancer incidence is probably reduced by about 3/4 once the virus clears, but we still believe they need to be monitored for hepatocellular carcinoma development, and then consider endoscopic surveillance for varices and cirrhotics. Downloadable sources that are helpful are the Hep C guidelines developed by AASLD and the Infectious Disease Society. This can be downloaded onto your phone. Extremely helpful. It's got references to Pew Child score estimates and FIB4 calculators and lots of other things. The University of Washington website, in combination with the University of Alabama, has the Hepatitis C Online, excellent for education, and another website that you should be familiar with. So in conclusion, we have among the highest prevalence rates of Hep C in the nation, and the new recommendations are that all adults get screened for Hep C. Insurance obstacles have largely disappeared, so we should screen and treat regardless of fibrosis and substance abuse history. One of the challenges of getting patients into treatment has been not only getting the diagnosis done, but also getting them to another office to get them treated by a specialist. Now we can reduce some of those potential sites of losing the patient by treating them in the primary care setting and maybe in other settings such as drug treatment centers, some of the, and some of the more novel settings such as the central city concern treatment in residential areas. Elimination of Hep C will require expansion of screening and treatment settings. An interruption of Hep C transmission will require treatment of the active drug users, try and engage them in harm reduction, potentially getting them off drugs if possible. And it's most effective when treatment with opiate substitution is combined with needle substitution. So the good news is Hep C is on the decline. The challenge is it's not declining fast enough to hit the elimination targets, so we need to start screening more patients, all adults, and treating them locally. Thank you.
Thank you, Dr.
Yes.
Just a brief question. For those patients who've been treated successfully and for hepatitis C, is there a potential for reduction in reinfection incidence? They develop some kind of immunity once they're treated or not?
So the question of those patients that have been treated successfully for Hep C, do they have any immunity that protects them from reinfection? The answer is no. And that's one rationale for, particularly for individuals that are at high risk for reinfection, to check genotypes, because that can help you establish whether you have relapse or reinfection. It'll most likely be reinfection. Relapse, if it's going to occur, will likely be within the first 12 weeks after cessation of treatment. Yes?
One of the challenges that's present in the community is the cost of treatment. I know it's come down from 80,000 to maybe 30 or 40,000, but for an underinsured or uninsured individual who are out there in the community, I mean, we can screen as much as we want, but that strikes me as a barrier to care.
Yeah, it's been a huge barrier historically. It's still a barrier, but having said that, these drugs, wholesale acquisition cost has dropped. It was what, 84,000 for Harvoni initially, and it came down to the 50 range. And then I didn't mention it, but the real drop in prices came when competition in the marketplace came in with these last 2 or 3 drugs made by other companies. It's down below 25,000, 24, 23,000. Now those are the wholesale acquisition costs. Among payers, as we know, it's a big secret. But rumor has it that it can be as low as half of that, among the big payers, what they're really paying for the drugs. And so, yeah, they cost more than they should. It's still problematic for uninsured persons. Medicaid in Oregon pays for it. They don't require absence. They don't ask you what kind of a doctor you are. All that went away last year. So if you can get them on Medicaid, they can and should be treated unless they have a very short expected lifetime, and it's recommended if they're going to die in the next year or two. Probably doesn't make sense. Yes?
I work in a clinic in Oregon City that takes care of indigent patients. Most of them are Hispanic. I'm sure a lot of them are illegal people who don't ask that, but I'm sure they are. What would you do if you had a patient like that?
Good question. In theory, they can't get Medicaid.
You can't get anything.
Can't get anything. Okay, well, there are a couple of research studies being done looking at generics internationally that will accept U.S. citizens. They're being conducted, some are being conducted within the clinical trials network. And the costs are around $1,000 or less, maybe less. So another approach is for people to get treated elsewhere. But there are ways of getting on these clinical trials with generics that are cheap. So I would look into that. Yes?
Are there any guidelines with regards to
The question was transmission among couples?
No, any guidelines with regards to when to attempt conception in infected couples?
Oh, in terms of with chronic liver, the risk of transmission among couples is low, so it's not recommended. The barrier precautions are required. Having said that, HIV-infected women and men probably have a higher rate of transmission, so in that situation, barrier precautions, but otherwise there's no specific recommendation. Yes?
So, Ken, one of the exciting things I heard you say, and I just want to verify it, is that the fibrosis is reversible?
Yes.
And at what stage of fibrosis was that
Yeah,
data?
right, this is exciting. We used to think scarring in the liver was like cement.
Right.
I remember I first heard about a case at NIH that got biopsied 10 years later in the 90s, had cirrhosis, they rebiopsied, and there was no fibrosis. And I go, I guess you can believe NIH, but that was amazing. And this study out of Europe that looked at a lot of cirrhotics, about half of them had cleared their cirrhosis over years on rebiopsy. So, and there's cirrhosis, and then there's cirrhosis. It's probably early cirrhosis with some of the earlier fibrosis development in patients with really more advanced cirrhosis probably don't have that reversibility. I don't think we know exactly, though that 49% number may be high, but it's clear that patients that are short of cirrhosis have regression, and there's a group of patients with cirrhosis that regress. So that's great news. Yes?
What are the prospects for an effective vaccine, which would likely be much, much cheaper?
Prospects for an effective vaccine. I heard a talk from a group from Oxford last year that are working on Hep C vaccines, and they have some promising results, but it's an underfunded area, and it's really being slowed down by insufficient funding. The emphasis obviously has been on drug development and clearing the virus. They think in the next few years they may be able to get something, particularly if they can get adequate funding to do the clinical trials they need to do. Thank you.
Great, thank you, Dr. Bennett. Excuse me. I think your slides are up. Okay. So there's this one, or do you want to use that?
Oh, sure. Thank you. Can you guys hear me okay? All right. So I just want to kind of give you guys a quick update in the time remaining on the COVID-19 update. If you guys haven't heard, there's an issue going on. So so in December of 2019, the Chinese first published some data reporting a novel respiratory illness that is now known as COVID-19 or the SARS-2 type virus. So this was from last night. It's been a rapidly developing situation. I think as this morning, there's over 94,000 cases, and I think there's over 3,200 deaths. It started in Wuhan, China, spread rapidly throughout China, and despite pretty draconian quarantine measures of quarantining over 50 million people in the Hubei province, it spread throughout the region, and as of now, I think there's over 60 different countries, including the United States, and I think as of this morning, there's 128 cases reported. Death rates is about 2 to 3%. That's likely to go down over the next over time, because right now I think there's issues in Hubei with not detecting a lot of these cases, so we're probably not getting true denominator data. What I think it's going to be curious to kind of see what happens over the next few weeks to months. I think South Korea is probably going to be more accurate as far as our death data goes. You look at 28 deaths in South Korea, over 5,000 cases. We're looking at probably mortality more akin to kind of seasonal influenza, hopefully. these are the cases in the United States as of last night. There's been about 124, 128 cases. With as of this morning, I haven't heard anything different, but there's supposedly been 9 deaths. The majority of those have been associated with a long-term care facility or a retirement home up in the Seattle area. Current estimates estimate the incubation period to be from 1 to 14 days, with a median of about 5 to 6 days. We believe that this is spread by large droplet nuclei. We don't believe that this is necessarily airborne. So we're talking about 6 feet or 2 meters in distance for prolonged periods of time. Touching objects and touching your face is going to be the highest risk. The R0, or basic reproductive rate, is estimated in most studies that have been published anywhere from 2 to 3. But this is still an ongoing studies trying to figure out what the true reproductive rate is. You know, the Princess Line cruise in Japan, they estimated it was about 2.3 or so. For comparison, seasonal influenza R0 is about 1.3. So when I say the R0, that's for each individual, they'll go on to potentially infect 2 to 3 other individuals that are susceptible. For example, like measles, which is airborne, it's estimated that the R0 is about 12 to 18 in a susceptible population. What we do know is that the majority of these cases are mild, so about 80% are mild, 20% are severe enough to require medical attention, and 3 to 5% will end up requiring intensive care unit care. The data seems to indicate that the individuals that are highest risk for severe disease and death are going to be our elderly population. So some JAMA paper recently estimated the death rate in the age greater than 80 to be about 15%, 70 to 79 to be around 8%, and then a little bit under 5% for ages 60, 69. Individuals with comorbidities like coronary artery disease, respiratory disease, immunosuppression, it's estimated to be quite a bit higher. Male sex, at least in the Chinese studies, seem to be a lot worse. Some of that was thought to be due to the high rate of cigarette or tobacco use in China. This is the CDC criteria to evaluate a person under investigation. What really kind of changed is that red box as of February 27th. Previously, we were just recommending, with a epi-link to either South Korea or to China, or now with Italy, Iran, and some of the other countries, to consider those people with respiratory illness, to consider them as suspects for a COVID-19 infection. But this, the bottom box there, fever with severe acute lower respiratory illness, pneumonia or ARDS without any other explanation, such as influenza, lobar pneumonia, etc., and no epi-link. So that really kind of changed overnight, and I think all hospital systems throughout the country are kind of scrambling. And that's most likely due to probably the belief right now, at least from some of the data from University of Washington, that this has likely been circulating in our community for at least the past 6 weeks or so. And part of that has been the issue with trying to obtain adequate testing. So currently, testing is only performed in Oregon at the Oregon State Public Health Lab with public health approval. We're recommending nasopharyngeal and oropharyngeal swabs and viral transport media. You can also use aspirates for nasopharyngeal or sputo or VALs. And we recommend ruling out other infections such as influenza and other respiratory viruses. This is more recent data from our lab looking at our respiratory pathogen panel. Note that area, that the pink line up there is influenza A. We kind of had a weird influenza season. We saw an early peak of influenza B, and now we're probably going to be in the midst of an influenza A peak based off of the most recent data put out by our lab. I think it was about 16.8% of our specimens in the past week were positive for influenza A. So I'm going to leave the remaining time that we have here for some questions. Dr. Drummond also might want to come up too to help me out field some of these questions. Yes?
What is the infectivity of it? How easily it is spread, especially would be nice to compare it to influenza. The other is the mortality. The mortality with influenza, I find, as 0.1%.
Yeah, so,
Whereas the mortality here looks like 2%.
Okay, so-
20 times
yeah,
higher.
so that's a great question. I think the data on mortality is gonna probably, we're gonna see that number come down. I think we don't know the true denominator data. I think in the initial phases of the outbreak in China, I think they were scrambling. I probably estimate that, if you look at all the aggregate data outside of China, based off of that Johns Hopkins slide I put up, I calculated the mortality rate to be under 1%. It's probably going to even out over time. I probably estimate that it's probably going to be between 0.5 and 1%. That's still during a seasonal influenza outbreak. Right now the early estimates are about 0.05% for this season, but we'll see this influenza A spike go as well. So I estimate it'll probably be more like about a 0.1. So you're looking at about 5 to 10 times potentially higher than that than influenza as far as infectivity or as far as mortality rate. Infectivity rate, we're still working on the R naught, trying to figure out how infectious it is. Question is whether we can contain it in the United States or not. The Chinese, they shut down all kind of social, they shut down Disneyland, movie theaters, and things like that, and they quarantined a large area. We'll see how that would go in the United States.
Can I just add one thing to what Justin said? Is some of those early. Okay. The only thing I would add to what Justin just said is some of those early studies that came out of China that have been published, when they look at the case fatality rate outside of Hubei province, it really was more like 0.2 or 0.3%. So.
And if you look, I think South Korea right now is probably, I think we're going to get more accurate data out of South Korea. Because currently they're able to perform last time I heard, about 10,000 tests per day in South Korea. So we're actually probably getting very good data out of those guys. And right now it's about like 0.05 to, or it's about 0.5% or less in South Korea right now, which is reassuring. Actually I heard they have a drive-through testing centers in South Korea right now. So kind of interesting.
Of course they do.
There was a question, yes.
Describe the situation in Clackamas County where I heard there was one case amongst elementary school workers.
You probably have better data on that than I do.
Yeah, sure. Because I live in that area and I get all the updates from Lake Oswego School District. Yes, so they confirmed, or there was a presumptive positive that it was announced Friday evening. And this is someone who works at Forest Hills Elementary. And ultimately, they do not believe that this person had really any contact with students at all and very limited contact with any other staff. Based on that information, Clackamas County, the state of Oregon, in conjunction with the CDC, decided that they did not need to do an outbreak investigation in that school. And I think what's even more reassuring is that individual, I think, has not been working since February 19th. So they closed Forest Hills Elementary through actually today to hit that 14-day incubation period. There have not been any additional cases that have come out of that school other than, so nothing from the school. And then we have another presumptive positive in a household contact of that index case. So they do think it truly is a very low-risk situation for that school and the community, although we, of course, were receiving a lot of phone calls over the weekend.
What's been the trouble with the testing? I mean, it should be a PCR test. Is it confused by other coronaviruses? Why does the CDC look so bad?
That's a good question. So the initial testing the initial test that was put out was sent out to the kits were sent out to the state local health departments about a month ago, and we were hoping to have had validation about 2 weeks ago. But initially, those tests, when they was trying to validate them, the state public health labs throughout the country were having issues with them. They were defective and they were sent back. The issue right now, it sounds like as of Friday, we do have the Oregon State Public Health Lab has had the test available. We have 2 test kits available in the state of Oregon right now. That's enough to run anywhere kind of from probably about 1,000 to 1,800 tests, depending if they're running them daily or they're batching them. The test kits are hopefully going to become more available. The FDA has now given approval for other labs to develop their own testing with rapid approval. The University of Washington has their own test that is now available to be able to be, that hospitals and labs can send their tests to.
Just to emphasize what Justin just said, as of last night, there are 8 commercial labs that are on fast track to develop PCR testing, and that's in addition to a variety of academic centers. And our own Providence laboratory is generating a PCR test. But those all have to be validated, so it's probably going to take several weeks, if not a few months, before we get the true easy access to PCR testing. Then we're probably going to find a lot more patients as this process proceeds.
Prof. Centralia, I was on a system call yesterday. Prof. Centralia got about 5 test kits, so they have about 5,000 tests in Washington right now. But Washington has over 27 cases, I believe, as of now. Question back there?
Before the question, can I just finish the thought? So I wanted to put up Justin's surveillance slide and have you look at the bottom legend. So you see all the viruses. When you order a nasopharyngeal swab, we get back a really great spectrum of viral agents. But we had this incredible confusion of a 30-year-old patient with severe ventilator-dependent pneumonia up in our ICU last week. And we got the viral swab, we got culture and sensitivity, et cetera, but we did not get a mycoplasma test. And because a year ago, the panel that we were using included mycoplasma and chlamydia, and the new panel, or the one that we are using this respiratory season, did not. And of course, there was a huge panic, and all the quarantine activities and protective activities were appropriately implemented, and all we had to do was order a mycoplasma test. So don't forget that not everybody has COVID-19. I mean, they may have garden variety etiology of their community-acquired pneumonia.
Or influenza. You had a question back there?
Yeah, do you know why the discrepancy between the CDC and WHO isolation guidelines?
You know, there's been some discussion about that change. So the WHO, so the question was CDC versus WHO guidelines for isolation, droplet versus airborne. CDC initially came out with recommendations that this is airborne disease. WHO came out saying that this is droplet, but you can also use airborne as well. I think WHO recommendations are most likely due to, I think WHO recommendations often deal with kind of under-resourced areas which might not have airborne isolation. From what I heard on a systems call yesterday, California Hospital Association has come out with recommendations saying that this could be potentially, you could use droplet in these situations. We will see if what happens over the next weeks as far as that recommendation goes, because I know there could be critical shortages in PPE throughout the country.
What about current antiviral drugs, especially those?
So there's currently a couple antiviral drugs. Well, so there's an older drug called Kaletra. There's been some in vitro data looking at Kaletra. It's a protease inhibitor. Some of the preliminary data that I've seen from China was equivocal. There's a drug called remdesivir, which was initially used as an Ebola drug that didn't really work well. But they have, there's current clinical trials going on at University of Nebraska. I think Spokane is also a site. That if you read that New England Journal paper from Everett, they got compassionate use for remdesivir from Gilead. There is some discussion right now about enrolling Providence as a site for a potential trial for remdesivir. So there are ongoing studies or ongoing questions about this right now. I heard about 4 weeks ago in China, they were supposed to be enrolling 340 patients in a remdesivir trial, but I haven't heard any preliminary data from that.
Do you have any recommendations for how clinics should handle patients that are calling out? Our clinic, for example, has 90 and 95 tests. Trying to figure out what to do.
Yeah,
Do you want me to
I know
field?
that Wendy can now.
So the question is, how should clinics handle protecting staff, correct? Droplet versus N95? Okay. Yeah, so a few ways to approach that question. First of all, in terms of our ambulatory care settings in Oregon within the Providence system, unlike some of the other ministries within Providence, we don't have any airborne isolation rooms, whether it's our urgent care, an immediate care, or a clinic setting. So that becomes really relevant in terms of our ability to do testing safely. And at this point, because the CDC is saying airborne isolation for any procedure that might cause coughing, expectoration, up till now, and this may change if they walk back the droplet versus airborne isolation recommendations, but we're not even able to do testing in the clinic setting anyway. In terms of the science and what we know about this virus to date, we do really think it is droplet transmission. So in terms of keeping caregivers and patients safe in the ambulatory care setting, first and foremost, the most important thing to do is just general, what we call endemic isolation, which is a patient walks up to check in, and the first questions we're going to ask them is, are you having any respiratory symptoms and or fever, and hand them a mask. So the single most important thing that we can do is mask a patient who is symptomatic, because that barrier is going to provide protection in terms of limiting transmission to other persons. Now, there's a lot of caregivers who are very concerned seeing news about N95s and airborne isolation, and I need to wear an N95, and that is simply not correct. The recommendations based on the science right now is that in the ambulatory care setting, if a caregiver follows standard contact droplet precautions plus eye protection, whether or not that's goggles and or a face mask, is effective in preventing transmission. I know that's a long-winded explanation, but hopefully that answers your question.
Yes.
Yeah, I wondered if you could comment on the case near Pendleton of the man or the person who collapsed at a
Casino?
basketball game.
Oh, no, the basketball game. I don't know any, I don't.
I don't
anything
know.
about that Umatilla case. I know they're in Walla Walla now, but I don't know of any, I haven't heard of any updates on FB-Links on that. We're gonna be on we're gonna be on a call with the the state health department today. We'll hopefully get some updates on that. Is there a question over there? Paul?
Can you describe the current process in the hospital for determining who's getting tested?
Okay, so the current process as far as who gets tested. Right now, testing is really kind of up to the decision with the provider and the county health department right now, because they are the ones that currently have access to the test. So in general, if you look at the criteria for people that are sick enough to get admitted, these are our criteria at this point in time. So this will likely change as testing becomes more available. And, if there are ongoing discussions, if you have a strong enough suspect, there's always going to be some leeway with discussion with the health department. But, this is kind of the guidance we're going off of right now.
When the person becomes infective, at what stage, and then what stage he is no longer infective?
Those are good.
The other question is, since mild cases have no fever, the screening at the airports that is limited to checking the temperature appears to be of very limited value. Please comment.
Yeah, well, I think a couple different questions there. How long are people infectious? No one's quite sure on that. As far as, there's been some questions about asymptomatic transmission. No one's quite sure on that either, but it's not felt to be a primary driver of this. The question about mild disease is probably the bigger question, which could, if 80% of individuals are only getting mild disease, that is going to make this a lot more difficult to contain potentially, because, if you're not sick enough to go to the hospital, you might not even think about this could be COVID-19 infection. And I think we're probably going to not know this until we get more post-hoc analysis much later on down the line. Jesse, did you have a question?
I guess I was just going off this. So in clinics, we're actually not testing, right? Because unless we're sending them to the hospital, we think they're sick enough to transfer, we're not gonna even request testing?
So the question is about testing in clinic, and I was on a call yesterday with the system, and there's been some ongoing discussion about whether we should be doing influenza testing in the clinic. And I expect that there is going to be new recommendations coming down in the next day or so about actually testing for patients for influenza in the clinic with proper droplet masking and contact isolation, kind of based off of that slide with the epi data showing that we're still seeing ongoing influenza A. So it's unfortunately until we've been hampered a lot by availability of testing, and we would all love to be testing these patients to kind of get a better idea of what's been going on in the community. Paul, did you have a follow-up? I'm sorry.
Yeah, I did. I mean, it seems to me like we're not even meeting the standard of testing. It seems like we're under testing, not even meeting these patients. I mean, as of yesterday morning, the entire state of Oregon, I think they're just under 30%. We clearly we're not having any severe respiratory illness. And so, I guess I have a lot of questions, but I mean, my first process, were you indicating that any individual provider can make the decision to test the patient in the hospital, and they should do that in conjunction with contacting?
No.
We don't have but if you have a strong, you can always talk to the health department and try to make your case, is what I'm trying to say. But ultimately, as it stands, as of today, you're not going to be able to get approval for testing without the health department approving the testing. Oh, all right, Alan?
So I've read varying things about the capacity to immediate effect after somebody has had the illness and cleared it. What is known about that?
Oh, I don't think we know.
There's not, I've read a lot of reports on that. I just don't think there's not enough information on that for me to be able to comment on that adequately.
I mean, it's a real conundrum, our inability to do widespread testing, especially to your point, in the outpatient setting, because the question is, if there is community-wide transmission, we have people presenting to clinic, influenza testing is valuable because it's nice to know if they have the flu, right? Then we can walk away from coronavirus. But there have been questions about testing for influenza or even strep, anything where you're sticking a swab and maybe potentially causing someone to cough. So we're hoping we'll have some clarity in the next few days, but it's evolving so quickly.
So the question is, if you have somebody with respiratory symptoms, fevers, we automatically put them in airborne isolation. Ideally, we'll get some of these tests. The recommendation right now is to put these patients in droplet isolation, like we do during normal flu season. So ideally, turnaround time for influenza, rapid influenza is relatively quick. Turnaround time for the 24 hours. So hopefully we'll get some of that information back. And then if you have, this is kind of where this kind of comes up, where you end up having patients with a respiratory-like illness, potential bad pneumonia, without a good explanation. That's when we start, that's what we're asking is, if you find somebody with obvious lobar pneumonia that looks like pneumococcus and you're getting positive cultures, or if you find somebody with influenza-like illness, we don't need to go down this pathway. So what we're trying to do is try to get, in our current iteration of thinking on this, since we don't have widespread testing, this is kind of what we're trying to do is rule things out. If they rule out and they have severe disease or they're sick enough to be hospitalized, then we might need to start thinking about going down that pathway.
And I would clarify, because this came up within the last couple days while I'm on call, is that we're really looking at lower respiratory tract illness, i.e. pneumonia or something more severe or a more severe manifestation. It's not someone who presents with fever and maybe hypotension who's had a cough, right? So it's not severe respiratory illness. It's truly lower respiratory disease.
And we don't, exactly. And we don't want to miss someone with meningococcal, meningitis or other types of, infectious disease processes. There's the home web page on the intranet has the links to the COVID-19 information. We put up recommendations for, initial recommendations for clinical care of the COVID-19 suspect. But, we want to get blood cultures. We want to work them up for other types of infectious processes to make sure we're not missing other diseases. Yes?
I was wondering if you could speak to what I've been hearing in the community and in the media about how it's going to get warm outside, so the virus will die. And I keep hearing that from my lay people friends.
Yeah, so there's definitely there's definitely seasonalities to
Coronaviruses,
to
yeah.
coronaviruses and a lot of respiratory diseases. Could we during the 1918 flu pandemic, they definitely saw a decrease during the summer months, but then came back. So there's some discussion whether this could right now. It's not declared a pandemic, but we're seeing it widespread. Pandemic is going to be widespread transmission through multiple countries with ongoing generations of infectivity. The question is whether this is going to become endemic, because we have 4 circulating coronaviruses that are that we see seasonally. This potentially could be one of those if it continues to spread and takes a foothold, but it's hard for us to know.
Because we know we see sporadic cases of coronavirus in the spring and the summer. I think the really important message, and everyone in this room is really powerful in terms of spreading the facts, right? Which is that, and Justin already referenced the data, that 80% of cases are very mild illness, right? We know that children are really not getting very sick with this illness, and younger people in comparison to H1N1 back in 2009. So these are really important messages to spread amongst colleagues and in the community, is that just education of the facts and to try to calm the anxiety.
I volunteer with a lot of underinsured and uninsured people. One of the big concerns in that community is if somebody has symptoms, what resources is there to get them access? Because the big concern is financial. Sure, what kind of bill are they looking at ending up with? So there's a lot of people who they may come down with symptoms, but they won't go get tested because they're afraid of the financial burden. Is there any kind of resource available to get people to get preventative testing?
That is a good question. I know that the county has had meetings with working with shelters and kind of the kind of high-risk clinics. I don't know what the billing situation is going to be like for the CDC COVID testing. That's a really good question, and we are definitely we've got a high we got a lot of homeless population in this county or in the Oregon area. These shelters could potentially if that goes around a shelter, it could be definitely of concern. And I know the local and state health officials are looking into this. I think it's a concern for them.
It's interesting because up in the state of Washington, so I've been on system calls, but there's also just news coming out of what they're doing at the state level because they did declare a statewide emergency. So that harnesses extra funding and deployment of the National Guard. That may take the form of just additional testing in the community and tents, but I know that they've been looking at other resources in Washington in terms of hotels and other, trying to look at those issues. I know that Oregon, I think that there was a bill passed within the last 24 hours of $100 million more funding directed towards coronavirus. So
Congress hasn't showed up though.
I don't know. I heard it on NPR this morning. So who knows? I did. Yeah.
The Republicans walked out, so I don't know.
Anyway, stay tuned.
Any other
It's
questions?
yeah.
What is the survival of the virus on virus surfaces as compared to other coronaviruses?
It's easily,
the same.
it should be easily killed by routine cleaning products that we use in the hospital, like Oxivir or quaternary ammonia products, bleach. So it's not like it's a super virus where it's gonna, but on surfaces it could potentially live for, I don't know what the
9 days.
9 days.
Yes.
So
Yeah.
that's why it's important to watch it. Hand sanitizer
Yeah.
works.
Hand sanitizer works very well.
Speaking of Washington, would you personally welcome visitors from Seattle in your home?
My sister lives in Seattle, and I get along with her, so.
Yes,
So
yes.
There actually have been some, Renton put out recommendations to avoid, we're gonna be doing more phone meetings and for business meetings not recommending, did you see that email?
I didn't,
Yeah,
but social distancing.
Social, but for, I think, this is for healthcare workers that are coming up to rent for meetings, so I think they're gonna try to avoid some of those meetings right now. There's probably gonna, as this develops, I would expect there might be some more recommendations for social distancing, but, as it stands now, there are, we haven't had any like official recommendations that we're gonna close down laser games or sports games yet, or movie theaters.
Good hand washing. Don't touch things. Don't touch your face. Thanks, everyone. Here's some Purell. Oh, God.